Hello, I'm John O'Neill. I'm a licensed clinical social worker and a licensed alcohol and drug counselor. I work in the Yale Addiction Medicine Consult Service at Yale New Haven Hospital. I'm here today to talk about relapse prevention in alcohol use disorder. What do we mean by relapse or return to use? The traditional ideal outcome for treatment of substance use disorders was total abstinence, making any use of alcohol a relapse. The concept of harm reduction encourages us to recognize that the goal of some patients will be to reduce or manage their use, and that works well for some. For patients not seeking abstinence who return to use, it can mean unmanageable or dangerous quantities of alcohol, or an increase in AUD symptoms like compulsive use and craving. What about the terms slip up or lapse? A slip or lapse refers to a brief one-time or at least limited instance of alcohol use after a period of abstinence. A relapse is a more prolonged return to alcohol use. A slip or lapse is often a temporary setback, while return to use or relapse signifies a more significant departure from recovery. For our purposes today, we'll stick with the basic terms, relapse or return to use. Alcohol use disorder is a chronic, relapsing, remitting disorder, which means that some, actually many, people return to use after an attempt to stop. Relapse rates for alcohol use disorder are similar to rates for other chronic medical illnesses. If people stop following their treatment plan, they're likely to relapse or have a recurrence of symptoms from their chronic condition. Relapse rates for people treated for substance use disorders are estimated at 40 to 60%, compared with those for people treated for high blood pressure and asthma, which are both 50 to 70%. Relapses are common and similar across these illnesses. If we treat substance use disorders like other chronic illnesses, relapse calls for resumed, modified, or new treatment, and the lessons of failure may lead to a successful plan. William White, who has studied, written, and spoken extensively in the addiction field, was known to say when discussing patients who had relapsed, they're confirming their diagnosis. And if we haven't made our point already, the Stages of Change model, or trans-theoretical model by Prochaska and DiClemente, includes relapse as a part of the process, not as a separate stage. This model treats relapse as a common occurrence, particularly during the action and maintenance stages, where individuals may revert to old behaviors. It's not a failure, but rather a setback that can be used as a learning opportunity to strengthen the resolve and refine coping strategies. So there's an argument that relapse can contribute to long-term recovery as patients redirect their approach and their plan and enhance it. Relapse may be part of the recovery process, but that doesn't mean we don't want and need to try to prevent it. The medical, social, and economic costs are simply too great. So what can we do to prevent it? We can use the biopsychosocial spiritual model for SUD treatment to look at the tools at hand. From the biological perspective, we can support patients with medications to address alcohol craving and evaluate for underlying mental health conditions. There are many psychological approaches available for relapse prevention, but we should all be aware of a couple of the basics. In the mid-1980s, Terry Gorski, in conjunction with Father Joseph Martin, developed a relapse prevention model that called for patients to identify their top 5 triggers for use and appropriate coping strategies. Still considered an essential tool, Gorski's model calls for repetitive written identification of triggers and coping strategies so the patient can learn to avoid and or cope with their triggers almost automatically. Also in the 80s, Alan Marlott introduced a somewhat more complex relapse prevention model based on an assessment of the environmental and emotional characteristics of situations associated with relapse or high-risk situations, identifying those characteristics and analyzing the individual's response to these situations, as well as examining the lifestyle factors that increase the individual's exposure to high-risk situations. This process enables the healthcare professional to devise strategies to target weaknesses in the client's cognitive and behavioral repertoire and reduce the risk of returning to use. Another similar cognitive behavioral therapy-based approach is the behavior chain analysis, which takes an in-depth look at patients' thoughts, feelings, and situations before and after drinking, and helps them understand what they are doing and why, as well as how to better cope without drinking. Perhaps the simplest, most direct approach is think through the drink. What's likely to happen if they take that drink? What's the likely effect on their job, relationships with their significant other, their family, their legal problems, or any other relevant part of their lives? Allow them to reflect and answer. Provide prompts if necessary. That reflection almost always results in an acknowledgement of likely negative outcomes. And you don't need training to use this approach. Additionally, help patients identify key supports, such as mutual support groups, key sober support people they can call on when they're feeling stronger urges to use alcohol. We can sum up actions we can take to help our patients navigate the perilous path of recovery as comprehensive plans, promoting adherence, and compassion. First, give patients comprehensive plans. A relapse prevention plan might include medication to address alcohol craving, evaluation for underlying mental health conditions, counseling to identify high-risk situations or triggers, and building coping strategies such as urge surfing, calls to mutual support persons, and others that resonate with the individual, like exercising or mindfulness skills. The term set them up for success may seem trite and overused, but the plan should be as comprehensive as possible with that goal in mind. Elements of a relapse prevention plan will vary for individual situations, needs, resources, and readiness. But we know medication combined with treatment, when the level of acuity and ASAM criteria support it, individual and/or group therapy, and peer support like Alcoholics Anonymous and Smart Recovery, or peer recovery coaches are all valuable elements. And again, does the patient have a co-occurring psychiatric diagnosis? And is that being treated too? For providers who are not mental health or addiction specialists, co-occurring psychiatric disorders may necessitate referral to a specialist. Referring a patient to a qualified addiction recovery counselor can make a major difference. Seeing a counselor regularly provides a foundation of care, and the counselor can make the referrals to a higher level of care if needed. Promote adherence to treatment. Follow up with care coordinators, alcohol and drug counselors, peer recovery coaches, family members, significant others, or whoever we can identify to support adherence. And last, but absolutely not least, treat patients who return to use with compassion. It's crucial patients come back to us when they relapse. The desire or just willingness to talk to us about their relapse can be a life or death matter. It's been said perception is reality, and any perceived condescension, arrogance, or hypercriticism can become reality for a patient and keep them from coming to us when they need our help the most. The best case is when they come back for treatment after relapse and they say they know they need our help. That's the goal.